Love that. Thanks for being here on this Friday morning. I'm Holly Brenner. I'm the Vice President of Strategic Development and Marketing and the President of the Agnesian HealthCare Foundation. I recognize a lot of the faces in here, so thanks for being here. We've got a great program planned for this morning. I'll start out with a reflection. We have something new to introduce to you that's just a quick 2-minute video on a new Know and Go resource that's available to us as associates, so I wanted to make sure to share that with you. But I will start with a reflection, a little Irish blessing. This is called Always Remember. Always remember to forget the things that made you sad, but never forget to remember the things that made you glad. Always remember to forget the friends that proved untrue, but never forget to remember those that have stuck by you. Always remember to forget the troubles that have passed away, but never forget to remember the blessings that come each day. All right, so we do have our HealthCare presentation scheduled for this morning with Dr. Lilly, Jennifer Burgess, and Jessica Harding, who are here with us. But first, as I mentioned, I would like to draw your attention to the large sheet that's on the table in front of you. This is a new resource that's available to us. It's a Smart Dollar program, and I think the best way to describe that to you is just to show you this quick video. And Danielle Risen, Danielle is in the back of the room, and she has more information on this program if you're interested, and I'm sure we'll be happy to talk with you after the program. So, can you watch that?
The average American pays out 1/4 of their take-home pay in debt payments. How much could you save if you didn't have any payments? How much could you invest in your 401k, your kid's college fund, if you didn't have any payments? Don't wake up 5 years from now and be the guy that goes, man, I wished. The time to start is right now. Personal finance is not about numbers. It's about behaviors.
Well, you got to be focused. When you can calculate and understand that I'm paying interest, it's a penalty, and if I'm earning it, it's a reward, that's a game changer.
You don't want to get to the end of your life and have nothing in your retirement account because you didn't make the money that you have behave.
The flow of money in a household really represents the value system under which the household operates.
It's time for us to redefine retirement. It's not an age, it's a financial number.
Normal in America is work your whole life and have nothing to show for it and be broke. You do not have to be normal. You got to reach that moment in time where you say, I've had it. What's in your wallet? Money. You can do this stuff if you just keep taking steps, even if they're baby steps. You eventually get to win.
Do this for your marriage. Do this for your family, for your kids, for your legacy.
You are taking control of your life and your money in a proactive, empowered way, and you're going to change your destiny.
So that's a new resource that is available to us as part of our Know and Go Wellness Wheel. Financial wellness is a big part of overall well-being, so please take advantage of that. It's available to us now. All right, so we have Dr. Lilly, who we all know as our cardiothoracic surgeon from the Medical College of Wisconsin, and Jennifer Burgess. Jen is here. She's the vascular surgery nurse practitioner for us, and also Jessica Harding, who is a cardiology nurse practitioner. We'll hear from all three of these individuals, beginning with Dr. Lilly. Are you all mic'd up?
I think I am.
Okay, thank you.
Is this on? Testing. Hello. Can you guys hear me okay? All right. Well, I'm Dr. Lilly, and we're supposed to talk about heart care here at this hospital. I think that you'll be hearing from vascular surgery, you'll be hearing from cardiology services in terms of things like heart failure and other things. I represent the surgical side of things. Wow. Yeah, I did my training at Duke back in the dark ages when you had to stay there all night long and all day the next day, and got maybe 40 hours of sleep a week or something like that, you know. But It was great experience, a lot of good work. And then my first job was at Brown. I was there for 5 years, and then I was recruited to the Medical College of Wisconsin. First of all, heart care, what are we talking about? And many of you here are involved in it. In terms of surgical care, we have, and I don't have any slides, so we have lots of different things that we offer. We offer both standard open procedures for things like coronary artery bypass grafting surgery, for valvular heart disease, and I would, looking at the numbers, most of our patients fall into sort of the other category, which is a combination of things. We do operations for valvular heart disease in conjunction with, for instance, coronary artery disease, or, and that's where you hear the term cabbage. Many of you have heard that term, I'm sure. We do other things like surgery for atrial fibrillation. That's the so-called Maze procedure. The Maze procedure, I started those when I came here. We're about 90% successful in taking people that are in permanent atrial fibrillation and making them have a normal conduction system. Interesting story. This came about because it was noted that little children, small animals, have no atrial fibrillation. And big animals, horses, whales, etc., and big hearts have a lot of atrial fibrillation. So a guy by the name of Jimmy Cox at Duke, where I trained actually, found that if you take a big heart and you make it electrically a small heart, that you can affect the patient's incidence of atrial fibrillation. And so one of the operations that we do here is to take a patient that has AFib, that has been on anticoagulation, including things like rat poison or warfarin, for years and years and years, and may have even been intolerant of it, maybe even suffered a complication because of it, and we correct their atrial fibrillation, and they no longer have to be on warfarin, which is a potentially life-saving measure in and of itself. So we started that here. We also do a lot of aortic surgery here. Turns out that patients who have aortic stenosis, narrowing of the aortic valve, that present in their 50s or early 60s, most often present because they have a congenitally abnormal aortic valve. Their valve has 2 leaflets, not 3, like a normal aortic valve. Associated with that valvular abnormality is often aneurysms of the ascending aorta and aortic arch. And in fact, John Ritter, anybody, Three's company, John Ritter, had a bicuspid aortic valve, undiagnosed, ascending aortic aneurysm, and collapsed and died on set because of a dissection, which is one of the complications that can occur. If you present to me with bicuspid aortic valve, we're going to make sure that your aorta is the right size. If it's not the right size, we're going to replace that portion of your aorta. And it gets into some fun things, like how much aorta do we need to replace? Well, sometimes we have to replace the whole arch or part of the arch of the aorta. If we do, then often that means we have to do something called circulatory arrest in the operating room, where we cool your body down to about room temperature and then turn off all flow for a period of time. We've got about an hour to work before you begin having problems, believe it or not. So we do those cases. I was the first person here that started that, and we've done quite a few circ arrest cases. Not so many of late, but we used to do 1 to 2 a month anyway. So that's in the works. In terms of lung surgery, which we're not really talking about a lot, but I do all aspects of cancer of the lung surgery. Most of it we try to do through little tiny incisions. Some of it we have to make a bigger incision depending on what we get into. So that's also part of the scope of my practice. Jen Burgess is going to come up, is going to talk about some of the vascular surgical stuff that we do and I've helped with, and we are actively recruiting a permanent vascular surgeon to fulfill most of that role. Getting back to heart surgery briefly, many of you have heard about these smaller incisions or even valves that can be put in through the groin. We do at this hospital often do small incisions for things like aortic valve replacement, things like coronary bypass grafting depending on the number of grafts, things like isolated valvular heart disease like, for instance, mitral valvular heart disease. To do that, we have to get you on the heart-lung machine. Usually we have to do that through your groin if we're going to do one of the smaller incisions. But a lot of people in their 80s that are retired or in their late 70s that are retired elect not to have these approaches because they do add some time in the operating room. They add some small amount of incremental risk, and they would rather not have to worry about that increased risk. So we don't do so many like we used to. I generally reserve these minimally invasive approaches, we call them, for people that are self-employed, people, painters, farmers, people that need to get back on the tractor in a couple of weeks, that are willing to accept that additional risk so that they don't lose work or lose their livelihood. So that's really about it from my perspective. What we do is very dependent on the people around me. My immediate team, we have a nurse and a physician's assistant, but we work hand in hand with the intensivists in the intensive care unit and everybody else, including the physical therapists, including speech therapists, including occupational therapists, and most importantly, including the nursing staff. One of the really nice things about this institution is that when you come to me for heart surgery and if you need additional time in rehab, we tend to send patients to our transitional care unit here at this hospital. The same physical therapists that have started working with you, the same speech and occupational therapists that have started working with you in the intensive care unit follow you up to the transitional care unit. And we've had some really, really sick people, for instance, that have made it through the process and graduated, and it's like your kid graduated from high school. Everybody's very happy, and it's a general celebration. So it's nice because it's a family environment, it's a smaller environment that I can keep my hands around so that I make sure that it gets squeezed when the right time comes to squeeze it in the appropriate direction. So, any questions? All right. I'm going to turn it over to Jen Burgess. Here you go, Jen.
Thanks. All right, I apologize for my voice because I'm getting over a cold. But anyways, I'm Jen Burgess. I'm the nurse practitioner in vascular surgery. I've been doing this for about a year. That's when we kind of started the vascular clinic. And one of the focuses of the vascular clinic was to offer various approaches to improve the quality of life for patients with vascular disease by ongoing collaboration and a multidisciplinary approach for patients who are in need of vascular care. What we offer in the vascular clinic is diagnostic testing, interventional or minimally invasive treatments, surgical treatments, long-term follow-up, and ongoing surveillance that is necessary with vascular disease. and also the management of vascular disease. No, this is a program about heart care, so I'm trying to incorporate why we work together with cardiac services. The difference between vascular services and cardiac services is that cardiac services will focus on arteries in the heart. They also evaluate the heart valves and the overall function of the heart. Vascular services will focus on arteries everywhere else in the body, including the legs, arms, stomach, and head. So arteries are important because they carry oxygenated blood away from the heart to the organs and limbs. If the oxygen-rich blood flow is decreased, then the tissue and muscle becomes damaged and can die. What can cause decreased blood flow in arteries? That's known as atherosclerosis, which is a disease where plaque builds up in the wall of the artery. Both peripheral arterial disease and coronary artery disease are caused by atherosclerosis. Symptoms of peripheral vascular disease includes pain in the lower extremities, burning or tingling in the feet, sores or breaks in the skin of the legs and feet, loss of hair on the feet or toes, changes in the skin color, and decrease in the skin temperature of the lower legs. Carotid artery disease is another area that we focus on. And the symptoms related to that are weakness or numbness on one side of the body, difficulty speaking, loss of vision in one eye. This may be intermittent, and it appears that a shade is being pulled over the eye and then goes back up, and also drooping of one side of your face. So how do we work together to provide the best benefit for our patients? Vascular and the cardiac services are located in the same location, even though we're very separate departments. But we're easily able to collaborate with each other when needed to provide optimal care, because we often see the same patients. And just to explain why we work together also, is that any patient that's undergoing any type of vascular surgery has a stress test performed to evaluate for coronary artery disease. This is important because if you have blockage in any of your peripheral arteries, there's a high risk that you'll have blockage in your heart as well. Many people with peripheral vascular disease in their legs are unable to stress their heart because they find their activity is limited due to the pain that they get in their legs when they have peripheral vascular disease. So these patients often do not experience the chest pain or increased shortness of breath that others would. Risk factors that contribute to coronary artery disease also contribute to peripheral vascular disease. These are the risk factors that we can control, which is smoking, diabetes. Those two are the most important ones. Hypertension, high cholesterol, weight, physical activity. Now I'm also going to touch on abdominal aortic aneurysms because that's also a large patient population that I see. There's 15,000 deaths per year due to abdominal aortic aneurysms. This occurs often because people with aneurysms often do not have any symptoms. People between the ages of 65 and 75 are more at higher risk with having deaths from their ruptured aneurysms. Abdominal aortic aneurysms, the risk factors are smoking, one of the biggest ones, uncontrolled hypertension, being male, genetics can play a role, high cholesterol, and also atherosclerosis. Screenings for abdominal aortic aneurysms. The recommendations per Medicare is if you've had a family history of any member having abdominal aortic aneurysm. Also, from the age of 65 to 75, people who smoked at least 100 cigarettes in their lifetime. This doesn't mean that we don't screen women who also have the same risk factors. And currently, I'm working with medical imaging on developing a screening for patients that is very affordable for them to come in, and if they want to be screened for abdominal aortic aneurysm, that they're able to do that. Not everybody knows that we also offer endovascular aneurysm repair at Agnesian. This accounts for about 78% of all intact AAA repairs in the United States. It's very minimally invasive. People recover, well without any problems generally, and they're not laid up for a long time if they have an open repair. But we do have to do some testing to see if you're a candidate for a minimally invasive repair of your aneurysm prior. So what can you do if you have peripheral vascular disease or coronary artery disease? And that's walk, walk, walk. Exercise, very important. Many patients who have peripheral vascular disease, if they get on a walking program, they may not even need to have any type of treatment. 6 to 8 weeks on a walking program, people find very successful. And we can keep them away from having surgery and going through any other hardships. Also, quit smoking. That's another very, very important thing that you can do. Eat a heart-healthy diet, and also take medications that are prescribed to you. They're prescribed to you for a reason, and they're also very important in treating your vascular disease. So next is Jessica, and she'll talk to you about heart failure.
Good morning. Can everybody hear me okay? I'm Jess Harding, one of the nurse practitioners in cardiology, and I'm going to talk to you today about heart failure. So although I do general cardiology, patients with heart failure are a large portion of what I see. Statistically, from the American Heart Association, approximately 6 million people in the United States have heart failure. About 1 in 5 will develop heart failure in his or her lifetime. This is expected to increase to 8 million by 2030. About half of people die within 5 years of receiving this diagnosis. Heart failure costs the nation about $32 billion per year, so that not only encompasses healthcare expenditure, but also lost wages in that estimation. A brief definition of heart failure. Heart failure occurs when the heart cannot pump effectively enough to meet the needs of the body. It doesn't mean that the heart has stopped working entirely. When the heart is weak, there is the potential for fluid to accumulate in the lungs, abdomen, or legs. So up top here is a normal heart. So the heart muscle pumps blood into the aorta in a healthy heart. Down here you can see this chamber is enlarged, and blood can pool in the heart, resulting in heart failure. Some risk factors specific to cardiovascular disorders, which increase somebody's risk of developing heart failure, include heart disease, having high blood pressure, diabetes, having a heart attack, rheumatic heart disease, congenital heart disease, having enlargement of the heart, valvular diseases like Dr. Lilly spoke of initially, stenosis, which is narrowing of the valves. Leaky valves can also increase risk for heart failure, and then abnormal heart rhythms. Atrial fibrillation, with which Dr. Lilly also talked about earlier, that also can cause heart failure because the heart beats fast and irregular, which can cause fluid accumulation. Symptoms of heart failure that patients may develop include shortness of breath, abdominal fullness, swelling in the legs, weight gain, they have difficulty lying flat in bed, fatigue, weakness, and also decrease in activity tolerance. So we started a program in the cardiology clinic in August for telehealth monitoring. And I'll go more specifically into telehealth monitoring in the next slides. But telehealth monitoring encompasses a lot of the important pieces of management of this chronic disease, to include medication management, no added salt diet, appropriate fluid intake, monitoring of symptoms, and then exercise. So although these are all pieces to management, telehealth monitoring does help encompass all of this. So inclusion criteria for having telehealth monitoring is that the patient has a primary diagnosis of heart failure. Exclusion criteria would be if they are unwilling or unable to operate the equipment. Current languages is English and Spanish. If their residence is not conducive or safe, if they're receiving hospice, or if they reside in a skilled nursing facility. So what the program actually is the patient is supplied with a device that they have in their home. They also have a blood pressure cuff and scale, and it all connects together. Daily, the patient is expected to do a health check. They do their weight, vital signs, and then the device actually talks to them, asks them questions, and then they answer yes, no on the box. Some examples: are you having chest pain? Are you having shortness of breath? And it's all driven based on the patient's answers. So if they do answer that yes, they're short of breath, it might then ask them more specific questions. So it is very, very tailored to the patient's situation. It also has education. So the device talks to them, incorporates education about salt intake, fluid recommendations, activity pacing, which the patients find very helpful. So every day that data gets transmitted, it gets reviewed. If there's been changes in the patient's condition or their weight is going up, for example, then myself or the other nurse practitioner gets notified. Then we reach out to the patients and hopefully intervene before they need to come into the emergency department or become hospitalized. The goal of keeping them at home and being able to manage this on their own. The program is 30 days. We do an evaluation at day 21 on every patient to see if it's appropriate that they come off, or we can extend that if appropriate. The hope, though, at 30 days is that the patient feels comfortable with their medications, they feel comfortable weighing themselves, and knowing what to do with that result, with the education that we provide in clinic, with the education that the device is giving them. Obviously, this is a chronic health condition that will need management from the patient every day. And we want to give them the support and resources so that they can do that successfully and stay living in their home. Goals of the program: patient-centered goals to encourage self-care, just like I said, so that they're able to do this on their own, so that they have an improved knowledge of heart failure as a disease, help the patient feel comfortable with home monitoring, and then the education. System-based goals to improve the quality of care. And then we have a hospital readmission rate goal of less than or equal to 18%. So we want to keep patients in their home, not having to be readmitted. Heart failure does have a very high readmission rate due to the acuity of the disease. So we want to reduce this rate as much as possible. And telehealth monitoring is one way that we are currently trying to do that. Yes.
What is the cost of the patient for this?
So currently, there is no cost. Agnesian is covering this as a service to the patient. So the device, the scale, blood pressure cuff, they don't get a charge. They're expected to return it when the program is done, as well as our monitoring of those patients through the telehealth program. They don't get a charge for that currently. Any other questions?
Sure.
Yes.
What can I be doing right now at age 30? I'm fairly healthy, but do have family history of heart disease. What could I be doing now that could help me in the future? I know that there are some things that are out of my control, but is there anything beyond the normal of exercising and trying to eat right that I could be doing?
Well, I think screening is important. So having your annual physicals with regular screening for lipid disorders, high cholesterol, glucose monitoring, so watching for pre-diabetes or diabetes. So having those annual screenings are very important to help detect early disease, because those are risk factors for development of heart disease.
The good thing is you're protected by being a woman. Estrogen is very much a protective mechanism in preventing coronary artery disease. However, as you age and reach menopause, for instance, that risk changes. So having a family history is critical knowledge. If you have a family history, particularly if you have a mother with coronary artery disease or aneurysmal disease, a mother if this occurs at an early age, that's a big, big danger sign, and you should seek screening earlier. But in general, women are protected because of estrogen. Men, there are a number of subgroups of people that, if you have a very strong family history, get screened early. Because a very strong family history certainly will be imparted to you in some fashion. Screening, we didn't talk about screening for one of the most common causes of heart problems, which is the vascular disease that can affect your peripheral vessels, but vascular disease that affects your heart, lack of blood supply to your heart, which can lead to heart attacks. We call it coronary artery disease or coronary atherosclerosis. One of the ways we have of screening that is with a screening CT for calcium score in the coronary arteries. It's a very sensitive way to look to see, is there calcium there? Does that mean that it's of significance to you in particular? No, but it tells you if you've got coronary artery disease beginning. And then you can begin things like changing your lipid consumption, not eating at Culver's every day, making sure that you're not a diabetic, because the time frame from initiation of diabetes until diagnosis of non-insulin dependent diabetes is often a matter of years before people are accurately diagnosed. And so you have that whole time frame where vascular disease can occur and worsen because of the diabetes. Certainly no smoking, making sure your blood pressure's under control, all of those things. Bill, can you tell us a little bit about coronary screening in terms of CT, what kind of availability we have right now?
Yeah, we've been doing it now for just a couple of years. It's a simple CT, non-contrast, only takes about 5 minutes, 7 minutes to do that. The cost is an out-of-pocket charge. It's not covered. It's a minimum fee, like Dr. Lee had said. It's a $25 technical fee, and then there's the radiologist read of that, which is $25 as well, so a total of $50. She used quite a bit. I'm sure Dr. Lee has seen some good things due to that test. So I'm glad that we have that here, and we'll continue to offer that. So it's quick, and it's easy to get into, and it's easy to have. So it doesn't take long at all.
So one of the things that we
There you go.
And I'm good.
Right. And so one of the things that we've seen actually are husband and wives that give it to each other as a Christmas present. And I've had like a number of husband and wife January teams that I've done coronary surgery on because they both had bad coronary artery disease and were diagnosed as a consequence of a screening CT. So it's something to consider. $50. I mean, it's a price of the same dinner that could cause your coronary artery. So I think it's worthwhile. I think these things are coming online and are not necessarily known to the general population as screening opportunities. When we say, if you have coronary artery disease as defined by a screening CT, what does that mean? Well, it means very little to you until we know, is that coronary disease of functional significance? So then that usually is followed by what's called a functional test, where you put people through a stress test, either a treadmill test or a chemical stress test, and see, is this causing lack of blood supply to the heart muscle? Is this disease early disease that we can just follow and try to modify your risk factors in terms of lipids, in terms of smoking, in terms of high blood pressure, in terms of diabetic management like we talked about.
How often do you get screened? I mean, how often should you come in to have that done?
Well, I think once, you know, so what coronary artery disease is and what vascular disease is, it's, you know, everybody's blood vessels get injured. You know, somebody runs across in front of you as you're driving your car and your blood pressure goes to 200, you know, and you want to yell and scream, you know, that causes some injury to blood vessels. The difference in people that have coronary artery disease and people that have no coronary artery disease or atherosclerotic disease is that you heal these injuries in a bad way. You take the injured vessel and you plug it up with calcium and cholesterol, and you create bone in place of where elastic tissue was before. So I think your question is a good one. I think really the screening test is just to see, are you the kind of person that creates these kind of abnormalities? If you're the kind of person that creates these abnormalities, you don't need to have ongoing screening CTs. What you need is a functional test. You need to get plugged in to a cardiologist or have your primary doctor perform stress tests on a reasonable schedule so that we know what's going on, so that we know if these blockages are causing problems. Blockages, knowing you've got that disease, okay. If you know you got the disease, now that's where risk factor modification comes into play. Whether you start, you know, getting the religion and changing the way you eat, changing to more a Mediterranean diet, for instance, the right kinds of fats, getting off our kinds of fats. A little bit of alcohol is probably a good thing. You know, finding a little bit, well, you know, a little bit for some of us is a lot for some other people. But, you know, defining those things and changing up your lifestyle and exercise and so forth is very important.
We have a question on the text line from Waupun. They are wondering if there's a screening CT available for them in Waupun and then also extend that to Ripon.
No, shame on me, I was just thinking about that. I guess I'm not sure. I gotta check.
So Bill Daly is the head of our radiology administration, so, well, he can...
Yeah, I'll get back to you on that. I apologize.
If that person calls the radiology department in Waupun or Ripon, they should have an answer to that.
Yes.
Dr. Lilly, could you just comment on your thoughts about the robust program that we have here and how unique that is to a community our size?
I think it's great. You know, one of the reasons I'm here is because I think our quality is excellent. I think the way we take care of patients is really above board for the most part. I mean, obviously there are things that can happen in any individual case, but I think we offer all lines of care except for heart transplant. We do have the ability to provide emergency heart replacement service if we need to. We have a ventricular assist device that we can implant in states of cardiogenic shock, meaning if you come in and you've had a heart attack and you have no heart muscle left and you're young enough to be considered for transplantation, we do have the option of putting in a device that can bridge you to either a more permanent kind of bridge or to transplantation. We have from A to Z capabilities. We can do endovascular grafts for abdominal aortic aneurysms or thoracic aneurysms, and it's remarkable to me that a lot of people don't know this. And we get calls even from our primary doctors over and over again saying, hey, do you guys do endovascular repairs of abdominal aortic aneurysms? And Jen says, yes, and we've been doing them for a while. So I think the message needs to get out there. I will say in terms of vascular services, which goes right along with the heart, obviously, is that we have a unique approach because our approach is a multidisciplinary approach. The kind of clinic we have is very much run by each one of the members that participate. You know, Jen is the point person, but then she connects to the people that need to be involved, whether that's surgery, whether that's intervention by way of cardiology or by way of radiology, or whether that's continued medical management, whether that's physical therapy, risk factor modification. And the other thing that we've done that is remarkable is we've been screening these patients with peripheral vascular disease very closely and have found, I don't know, at least 3 patients, would you say, that have had lung cancers that are in early stage that we've resected or treated otherwise, so we've saved their life from a lung cancer perspective. Patients, a number, more, I can't even count, how many that have had significant coronary artery disease, including left main coronary artery disease, which is the worst kind you can have, that has resulted in either surgery or other intervention. Because when you have vascular disease, whether that's coronary vascular disease, as in ischemic heart disease, or whether that's peripheral vascular disease, you've got vascular disease. It's the same process, affects everything. Your brain, your carotid arteries, your heart vessels, your leg vessels, your abdominal aorta, all the way down. So I think in terms of a community this size, it's soup to nuts, you know? I think it's everything. I think, and we do it well.
A person who is on long-term antihypertensive medications, do they have a significant increased risk of CVAD?
Yes. Hypertension or high blood pressure does increase your risk for heart failure. So the goal of treatment is to make sure that your blood pressure is adequately controlled on the medications that you're on, and that will help reduce that risk. When blood pressure is elevated, it puts extra stress and strain on the heart muscle, which can cause it to enlarge and not to work how it should. So keeping your blood pressure adequately controlled will help reduce that risk.
I guess my question more, does the medication play any kind of part in the CHF? So I actually heard people say that being in long-term antihypertensives, they also have a play or a part in CHF.
So the medications themselves, I would say no.
I mean, no one's ever done that study where you have a patient that's hypertensive and not treated with medications, and a patient that's hypertensive and treated with medications, to see do medications in and of themselves cause people to have heart failure. You know, that hasn't been done. It won't be done because it's the reason that people develop heart failure is often multifactorial. And what we do know is that if you have high blood pressure, your heart will thicken and your heart will not relax well. It will become muscle bound. And if it's muscle bound, it can't relax well, then it has to have very high pressures to fill. And when that occurs, then you get what we call diastolic heart failure, where fluid really does back up in the lungs and backs up even to the right side of the heart. You get swelling in your legs, swelling in your belly. Often you get early satiety, you know, you don't want to eat as much. You can have pain in your right upper quadrant from your liver being distended. You know, all of these things go with this sort of end-stage heart failure that we see. What we know that protects people from heart failure is changing up their loading conditions on their heart so that the heart can relax better over time, and that means decreasing their systolic blood pressure with medications. And there are a number of medications that are used, beta blockers, ACE inhibitors, alpha receptor blockers, calcium channel blockers, etc. And so people may end up on 2, 3, 4, 5 different medications, and that may be another issue. It may be that they've got renal artery disease that's contributing to their hypertension, and we have treatments for that as well. So we've got the full spectrum. If you come here, you have vascular disease, we're going to treat you one way or the other. We're going to figure it out.
Speaking of risk factor reduction, do we know how well we're doing with our high-risk population in terms of achieving LDL, blood pressure, blood glucose, and heart failure patients target medications in those customers?
It's a very good question. And I, on the surgical side of things, we track our medications that are administered at the time of discharge, whether they're given a statin, whether they're given the appropriate blood pressure medications, a beta blocker, etc. But in terms of long-term therapy, I would defer you. Do we know that? Do we know those numbers?
Not that I'm aware of. Currently, we're really tracking the readmission rates, but we are having ongoing discussion about utilizing a hospital-based program that does track those measures. I can speak for myself. When I do see patients in clinic, we do manage their risk factors. So I do treat their high blood pressure. I do treat their cholesterol to goal. We do make sure that they're on an aspirin if appropriate. If they do have uncontrolled diabetes, we do that referral back to their primary. And we do make sure that those other risk factors are controlled. I think our cardiac team takes a very holistic approach to patient care, which I think is very important. So not only do we specialize on what we're seeing them for, but you have to look at their health in general. So we do treat those risk factors. Are they tracked? I don't know.
Yeah, Jen, maybe you can speak to this. Like, how many of your patients who come with peripheral vascular disease are on appropriate medical therapy for vascular disease?
Not many.
Yeah, and you know, the issue is why, I mean, well, often they're self-referred, but often it's, patients read about so-called statins. And I mean, you all know about statins, and statins can cause, sometimes they're very poorly tolerated, or people read about it and they say, wow, there's no way I'm going to accept these risks, because of the potential liver injury, the potential muscular pain. Well, there are other medications that we can use as well. But so sometimes it's about patient compliance, patient's desires, but sometimes it's about just primary care. I mean, not necessarily being there, being so tuned in, or being involved in that particular patient. So we get these patients that come, and boy, we've seen them. They come in with, vascular disease, a leg, foot that's black or, rotting away because some poor farmer he hates doctors, and that's just the way it is. Doesn't want to lose his foot, but he's been, thumping around for a long time with a rotting foot, Comes in, well, sure enough, this guy's got not just this vascular disease, but coronary vascular disease, lung problem, cancer, potentially, and often this is their entry into healthcare. And so we get them on statins, we get them on beta blockers, we screen them for other vascular and lung problems, and make a difference in many of their lives. Yeah?
What types of carotid procedures are we doing here?
Yeah, we do carotid artery stenting and also surgery. So if you come in with a blockage in your carotid artery, number one, the way that you screen for that is first listening, but that's not 100%. And if there's a high risk, then we'll do what's called a carotid ultrasound duplex study. That is a very good test for looking at what grade stenosis you might have. People that are easy to decide who gets treated are those that have symptoms. And Jen went over a couple of those symptoms of things like blindness in one eye or the other, or weakness on one side of the body or the other, like a mini stroke. The mini strokes that get better, we call them transient ischemic attacks, or that actually have strokes. Those patients are easy to decide, you got to treat that stenosis that's there. It's the patients that don't have symptoms that we have to decide how we're going to treat them. And many of those patients will come to surgery because they have a significant blockage. What we found, there's a study called the ACAS study that is an old study, but has demonstrated that carotid artery disease greater than 60% stenosis, as defined by carotid ultrasound, those patients are best managed with surgery in terms of their long-term outcomes. So greater than 60% stenosis, we should be seeing those patients, we should be following them, we should be making a decision as to if they're going to get an operation or not. If you have asymptomatic carotid disease, meaning you haven't had a stroke or blindness or something like that, the only option for you is surgery. If you have symptomatic carotid disease, we do have this decision point: are we going to stent it? Are we going to operate on it? And that really depends on the overall health of the patient and maybe the overall treatment plan. But we do offer all of that here. Yep.
They say one glass of wine a day is good for you. In your opinion,
is this a glass like this?
In your opinion, they say, some people say red wine is better than white wine.
Yeah.
White zin isn't any good. In your opinion, what do you three think is the healthiest for one glass of wine a day?
Yeah. I don't. Yeah. Again, I think that the benefit has actually been seen in alcohol in general, but some people feel that the various antioxidants that are in the red coloring that come with red wine is better. No one's really shown that 100%. The initial data was red wine, and so I think if you want to be a purist, red wine, a glass a night, it's probably good.
Thank you.
All right, thank you very much. Great presentation. Thank you for your time. Has everyone turned in their green slips for today?